outcome is finally the key issue, whether it is postoperative complications, local recurrence, or survival. Recently I realized that R1 resection is an issue in some series. So we looked into our material, and the R1 resection rate, and this is the classical one, which means tumor reaches the tumor front, is just 0.3% in all patients, finally 0.9%. And again, emergencies are included in this material. And one argument is frequently, we just treat advanced cases. But when we look into these cases in our register, the R1 resection rate did not increase. So this is an issue which has not touched adequately in the past and may be one reason for local recurrence. Now, postoperative complications, they are really relevant. And again, including about 10% of emergencies, our overall morbidity is a bit more than 20%. The rate of leaks varies a bit over the years. Sometimes it's below 1%, so sometimes it's almost close to 4%, so it is varying. And therefore it is important that you check your anastomotic leak rate every year and look for reasons why it did eventually increase. So sometimes reoperations are needed, not for postoperative bleeding, which is rare, but maybe for obstruction and for leaks with following peritonitis. So finally, our overall in-hospital mortality is 3.3%. And this is not 30 days mortality, because probably 1/3 of the patient dies beyond 30 days. So this is all hospital mortality included. Now, local recurrence. We have talked about that earlier in one of the chapters. Should be rare, but it's not zero. And in our patients, we have the highest rate with stage 3 at close to 10%, which again means lymph node dissection seems to be important and can be even improved in some situations, and I think mainly with transverse colon cancer. Finally, this slide presents our survival figures, cancer-related survival. It is 100% in stage 1 and more than 90% in stage 2. And finally, almost 80% survive now in stage 3 in cases of RC resection, which means mainly without distal metastases. And what we should do and need, if this concept is accepted by many surgeons and if they are able to achieve similar figures, is a study on the need of adjuvant chemotherapy in patients with 1 to 3 lymph node may be involved. And this is to be questioned, and the study is needed. Finally, how can we achieve high quality in many centers with many surgeons? And so I just want to come back to the way we improved our results, and it starts with documentation. Any operation for surgery needs documentation, including the surgeon who performs surgery. And then you have to analyze the results maybe every 3 or 4 years, ask for deficits, and find guidelines in your department that have to be followed strictly. And that's what we did all the years. And so we improved step by step over the periods in recent years, and finally are now survival of all patients operated are 0 with colon cancer. And we are also able to trace back any patient to the surgeon who operated. And each of these lines represents an individual surgeon, and we are very close on a high level. And the gray line are the young surgeons in training. They do a bit worse than the rest is doing, but in this group, the learning curve is still included, and if you looked at their figures 5 years later, they would certainly be within the range of the other surgeons. So quality management is important to improve results, to set guidelines and watch whether they are strictly followed and document everything. And then all of this will lead finally to better outcome with colon cancer surgery.